So next, we're going to have Dr. Kiran Patel and Cole from Abbott. They're going to show us dorsal root ganglion spinal cord stimulation.
Hi.
Hi. How are you?
Awesome. Thank you for having us here.
Oh, my pleasure.
Thank you.
My pleasure. Let's see which slides.
Awesome. Wonderful. So I'm excited to be here and to talk to you all about dorsal root ganglion stimulation. And I'm sure many of you who are out there have seen me on social media or met me at a course and know how strongly I feel about this therapy. I've been practicing interventional pain medicine for about 12 years. And, this therapy didn't exist when I was in training, when I was a fellow.
Same here.
And it came out after, I was already in practice, and it has definitely changed the way I practice.
Absolutely.
And has renewed myself, as a practitioner, my excitement about treating pain. Because I like therapies that work. I like that for myself. I like that for the patients. I like that for our field. And dorsal root ganglion stimulation is a very effective treatment. And it has truly transformed the way I practice and the outcomes for my patients.
I could agree with that.
And so, when I say I like therapies that really work, we know from the Accurate study, which was, put forward by Abbott as an IDE study, that after 12 months, 86% of patients had 50% or more pain relief. A year out from receiving an implanted system, 86% of patients had 50% or more pain relief. That is a staggering statistic. And that, to me, for patients who have CRPS types 1 and types 2, that was really the nails on a coffin of the 50-50 club. No longer do we have to talk about 50% pain relief for 50% of the patients. Right. We're talking about much more significant level of durable therapy and much more effective therapy. So that being said, dorsal root ganglion stimulation is indicated for CRPS types 1 and types 2 from the levels of T10 to S2. With the durability of this therapy, we are now exploring new areas where we may see official indications for DRG therapy, but at this time, it's focal neuropathic pain, CRPS types 1 and types 2. This is one of my favorite slides up here. This is from the DRG paper that we wrote, the consensus guidelines, the NAC guidelines, and you'll see here, it talks about which particular areas of the body have significant innervation. And so this is kind of a great roadmap for those of you who are starting to implement this therapy to try to decide where you're going to place particular leads to stimulate different areas of the body. And so I certainly, think this is a slide that we all should know and be familiar with and certainly have it handy to go back to.
That's a great reference. Absolutely. Yeah. Especially if, you're just starting to tackle things like groin or foot that you normally wouldn't have done as a traditional spinal cord stimulator.
And I think what's interesting is that, when you're talking about CRPS types 1, right, that's the classic Budapest criteria. But I would say that's the zebra and not the horse. The horse is CRPS types 2, which is a known or suspected peripheral nerve injury. And we see this all the time with post-surgical pain. And the other reason that this chart is so important is that sometimes we have to peel back the onion. You have to find out where was the patient's actual nerve injury. And that is going to allow you to figure out actually where it's best for you to place the leads. Sometimes it's not just in the area where they feel the pain. That's obviously very useful as well. But if you peel back the onion, as my rep Larry loves to always say to me when we're putting our heads together, you can help decide where you may also want to stimulate to completely cover the patient's painful region.
Absolutely.
So this is another one of my favorite slides. Yes, I do have favorite slides. It stands to reiterate the fact that the position of the dorsal root ganglion is consistent from patient to patient and from level to level. It's directly underneath the pedicle. You know where to find it. One of the challenges of dorsal column stimulation for CRPS is that you're often trying to map out a very specific region, and that can vary, right? What is physiologic midline is not always anatomic midline, and that can vary from patient to patient as well. With dorsal root ganglion stimulation for CRPS types 1 or types 2, it's much more predictable in terms of where you need to place your leads and in terms of, where you're going to stimulate to, cover their painful region.
Yeah, you no longer have to hunt for that sweet spot as you would in dorsal column.
In addition, with the differences about the dorsal root ganglion is that there's a very thin layer of CSF around it, as opposed to with dorsal column stimulation, there's a amount of CSF that we know can vary with positions, as intrathoracic pressure changes, if someone coughs, if they try to run, if they try to be more active. And so with that, you don't have to really face that at all with dorsal root ganglion stimulation. This is another great depiction of all of the real-world data that reiterates the types of outcomes we've seen with the ACCURATE study. And it says 1,077 patients. This is actually growing and continues to grow. Over 24 studies, 9 years of data. This is something that continues to be very well studied. Next slide, please. Cole, do you want to talk a little bit about the system itself?
Thanks, sir. So Abbott's DRG system is the only FDA-approved technology that's actually designed to stimulate the DRG. It utilizes a proprietary delivery sheath that you can see here is actually curved, and it helps navigate the lead towards that desired anatomical target.
Awesome.
Thank you.
Actually, use the other camera. It's easier over here on this side.
Oh, you like that? Yeah.
That way I can leave that one to the side. There you go.
The battery itself, the IPG, is a Proclaim series, so it is recharge-free, lasts on average about 6.5 years. And the iOS platform that we have is extremely patient-centric. It's easy to use. It's wirelessly controlled by the patient, and it is MRI conditional.
Something else I like about the iOS platform and the whole experience of Neurosphere and MyPath is that, the concept that we're able to reprogram patients remotely.
Yeah.
It's a huge advantage. I'm in New York City where to get to see me, you could be, a few blocks away, but it could take you up to 45 minutes in order to get to my office. Someone like Dr. Jameson, who's out here in Idaho, it could take patients a long time because they're coming from a large geographic distance. So these things matter, right? And so if there's ever an issue with the device, we're able to be more on top of it. We're able to be more ready with it.
With telehealth, I think patients have gotten used to
seeing
their doctor virtually, using more technology to connect, and it's great to have this type of technology to be able to program them remotely as opposed to them having to keep coming back into your office to do those things. So let's get started here. Let's showcase this. This is
Sure. All right, let's take a look where we're at here. Oh, can you move north with the CR, please?
You gotta move the table.
Yeah.
And so today what we're going to do, we're going to demonstrate the contralateral approach. So what's really important with this, is to make sure that when you enter the epidural space, you really want to be midline. You want to be directly above the spinous process. And you want to make sure, just like you would with any SCS procedure, you want to make sure that the end plates are sharpened up before you're entering that particular epidural space. And then make sure that you're as close as possible to midline.
Now, is your entry a little closer than it normally would be?
Yeah, it is. It is actually. That's a very good point. I often forget that. It's funny. My approach for dorsal root ganglion stimulation has changed how I do all of my SCS. And when I teach my fellows, I say that I want you to enter the space. Image, please. Just like you would if you were doing a DRG, so that when you do have a DRG case, you have that muscle memory and you're used to it. So at this point, I'm using the sheath, which we just showed you, which is designed to have that nice large curve to easily facilitate the placement of the electrode right over on top of the dorsal root ganglion. Now, as you can see here, you see there's 4 electrodes on each lead. And so what I've done is I've positioned my sheath right at the foramen there. And now what I'm going to do is just gently tap with the lead. Image, please. And we're going to see that the electrodes are out the foramen. And so the perfect position for the lead is that you want electrodes 2 and 3 directly underneath the pedicle. So at this point, what I'm going to do is use kind of a push-pull technique. I'm pushing my introducer back, pulling it back rather. And I'm pulling it back to the spoon of the needle. Image, please. Awesome.
I just want to point out too, here, you guys can see the tip of the stylet is there, and then there are all the electrodes. So you can make out the tip while you're working, which is super helpful.
Picture. Picture. Okay. And so now, there are 2 different techniques you can really do to make the loop. I think always doing anything when you're doing a procedure to take a less invasive approach is always a great thing. So at this point, I always say when I'm teaching people, I say, lock and change direction. So now I'm turning everything toward the patient's head. And what I'm going to do is I'm going to unlock the sheath and I'm going to advance. I'm going to take a little bit of the stylet out. I'm going to advance the lead. Image. Oh, it's escaping us. Image. So this is about making the strain loops. And the strain loops are really going to help keep things in place. Picture. Picture.
I really like this technique
Picture.
for pushing that first loop with the stylet like you're doing. And I think that this whole loop process is what I think is most intimidating for new learners, right? I think that's the part where they're like unsure if they can do it. But once you practice this and you get the muscle memory for it, it really becomes very smooth process. And also, I think just a very enjoyable procedure.
Yeah.
I think it's a fun procedure to do.
I love it. I mean, as you all know, I love it. What else can I say?
No secret.
Yeah. So can we move the table down a little bit?
Sure.
I just want to make some points about loops. So I say, people often ask me, what's the most important thing to know about DRG? 3 loops and an anchor, okay? And when we say loops, you really don't need the superior loop to go above the superior end plate, and you really want it to hug the pedicle, because that's the whole purpose. So if you get that first loop in there and it's hugging the pedicle very nicely, it's going to do its job. And then the second loop, we're going to bring the introducer back to the spoon of the needle. Image, please. I'm going to lock it. I'm going to turn everything toward the DRG. And what I'm going to do at this point is I'm going to push and pull. When our lead is floppy here, I've removed some of the stylet. And we're making that inferior loop. Now, I'm going to let you guys in on a secret. A technique I call closing the loop, right? So all you have to do here, lock, turn everything back toward the head, take an image, and you'll see that now all you have to do is just advance more lead, and that's closing the loop. And now you have nice 3 loops rather. Sorry. Image. Nice.
Nicely done.
So 3 loops and an anchor. So let's talk about anchoring for a little bit, right? So one of the biggest criticisms from colleagues in the field, from people who who've never touched DRG or maybe done 1 or 2 cases, is the potential for lead migration and lead fracture. Okay, so I was fortunate to be part of a real-world study where we looked at outcomes for when we were anchoring leads or when we were not anchoring leads, and comparing that to when we were using the silastic anchor that's included in the kit. And so what we found is that, we pulled our data from a bunch of physicians all over the country. There was a migration rate of 8.4% for unanchored leads. With the use of the silastic anchor in the kit, we were able to bring that migration down to 0.6%. Similarly, the fracture rate was 3.3% and we were able to bring that down to 2.2%.
Wow.
3.1 to 2.2. And so what that stands to reason is that leads that are not anchored are 6 times more likely to migrate, and 1.26 times more likely to fracture. And if we use the anchor, we're able to reduce the risk of fracture down to less than 1%, 0.6%. So the statistics don't lie. I mean, that's real world data, So I always say 3 loops and an anchor, and you're not going to have migrations. You're not going to have fractures, unless something crazy happens to the patient, or they're doing crazy yoga poses and stuff and not listening to you.
And I think that was a great study, because before that, I think the general consensus was you didn't have to anchor.
Yeah.
You make your loops, and that's going to keep it pretty retained. But that difference, that 6-time difference with migration is huge. So it's absolutely essential to keep that in your wheelhouse and in your planning.
Absolutely. And, does it add a little bit more time to the procedure? It does. But you know what? These are the patients who, when they have loss of therapy because of a migration or a fracture, they are breaking down your door. They are crazy. They're like, I need it back. Doctor.
Right. Something happened.
It
was perfect. And
there's no virtual explants, right?
Yes.
And for those of you who are familiar with that term, it's a concept that a patient has an SCS system and it's not explanted, they just have it off and they're not using it. We don't see that with dorsal root ganglion stimulation. If patients have loss of therapy, they are adamant about having a return to that therapy. And so, 3 loops and an anchor. That's definitely what we need to do.
Great advice. Now, in terms of your practice, now that since you've been doing this, what percentage of your stim is traditional and what percentage is dorsal root ganglion stim?
I think
she's like, it's 100%. It's 100%.
The vast majority of it is. I would say more than 80% of my practice is certainly dorsal root ganglion stimulation.
That's phenomenal.
I'm a big believer in vetting the technology, of reading the papers, looking at the real world data to see if it also corroborates those industry, design studies. And if it does, then, those are the therapies that I want to implement for my patients. And then I want to see that at my own hands, I'm able to reproduce those results as well.
Absolutely. How does someone get a hold of you guys? They want to get trained, and then who is the right person to get trained? What kind of skill set, foundation should they have to think about adding DRG to their armamentarium?
I'd say probably the easiest way to get a hold of someone about training is to just contact your local rep. I would say start there.
Okay.
They can put a phone call in to Abbott to see where and when the next DRG training courses might be. We do some on a regional level, and we do the majority of them down in Austin. So I would kind of check with them and see what that Prof Ed calendar looks like.
I would also say you got to walk before you run.
Yeah.
And no disrespect to anybody, but you have to have had a strong background in SCS. Have done some SCS trials and implants. Been trained maybe in a training program that does a good volume of SCS, and has an exposure potentially to DRG. I think these things are really important. But you gotta be able to walk before you can run.
100%. I think if you're someone who is having trouble steering a traditional dorsal column lead, then you really got to get that down before you start getting into this.
Absolutely.
I agree.
Absolutely.
In terms of the patients that you've had who've already come to you with a traditional system, has this been really helpful to you with those cases where they have residual pain that's still left over that's not being covered?
Absolutely. So this therapy has been great for patients with CRPS types 1 and types 2, and as a primary treatment, where I'm the first person offering them this therapy. Great, they do amazing. But there are also patients who come to all of us, who have other spinal cord stimulator systems in place for the management of CRPS types 1 or types 2, and they may be struggling, or they may have exhibited habituation, right? That's a real phenomenon. And so for those patients, this has been really a game-changing therapy. We're able to kind of restore, what was once a very good and effective therapy for them. We're giving them a neuromodulatory therapy that is very different, but allows them to, continue with a reduced reliance on opioids or other medications. And that's very substantial. And then, lastly, there are patients who are in love with their primary system, and there are patients who have one area that they're missing, and they will do anything just to cover that one area, but they want to keep their other system. And this is helpful for them as well.
Absolutely, absolutely. In terms of number of leads, do you have a sense of average number of leads that you've been using in most of your patients?
Yeah, so the IPG can support 4 leads.
Right.
I would say, at the very least, 2 leads. Why? We want to be positioning our leads such that the electrodes 2 and 3 are underneath the pedicle. If that moves a little bit, there is a little bit of forgiveness with the programming. So say I have a lead that has moved slightly and it's not optimally where I want it, right after the implant, but I have the second lead. I'm able to use the programming to cover that area as well. So that's often very useful. In other situations, such as pelvic pain, the combination of L1 and S2, myself, Dr. Corey Hunter, we've published on this and spoken extensively about it and how effective it can be for certain types of pelvic pain. Those 2 leads, they work very synergistically. So in some cases, you can kind of get a double coverage. In some areas, they work synergistically. So again, it really goes back to that concept of peeling back the onion and patient selection and lead selection, based on where the patient's pain is and their injury was.
Absolutely. I think you touched on pelvic pain. There are so many different pain scenarios and areas of the body that we can tackle with this system that we couldn't before.
Absolutely.
And it opened up a whole new world for our existing patient base and for just going out to the community and letting them know that this exists. A lot of them don't know.
Yeah.
A lot of them don't know anything about spinal cord stimulation, much less dorsal.
So true. I meet so many patients who have had persistent surgical pain, neuropathic pain after hernia repair, after knee replacement, after hip replacement, and they really thought, well, I'm moving better, but I guess I have to live with this.
Right.
And then when we tell them that there's something else we can do that's really durable, they're super excited, and you just see that it changed their overall activity level, their overall relationships with with their families, and just engagement.
100%. Couldn't agree more. Well, that was awesome. Thank you
so
very much. Great job. Thank you, Cole. You guys did awesome. That was Abbott, guys, with Dr. Patel and Cole. We really appreciate them coming over. And next up, we're going to talk about Clint Pharmaceuticals. So Clint Pharmaceuticals is a brand